Rick and Danny Show.
Hello, everybody. Welcome back, or here for the first time. I don't even know what to say, but yeah, this is our newly entitled podcast, The Rick and Danny Show, presented by Cancer Specialists of North Florida. Still without a title sponsor. Hopefully, Duncan soon. Duncan TBD.
Please listen to us.
Yeah, Duncan TBD is what we'll put for now.
I'm going to start tagging them now that we'll have new social media.
Good. Yes.
Yeah. I think, if we can tag all the locations, just tag them all. Someone will come around.
Plug it. Tag them all.
Actually, I'm wondering if someone in one of our neighborhoods might have a franchise that we need to talk to them about it, you know. So I'm just throwing things out there.
You know what? I could write a letter.
So,
Just write a letter.
anyways, but yeah, welcome everyone. First episode of the Rick and Danny Show by Cancer Specialists. Rick, how you doing?
Living the dream, man. How are you, Danny?
I'm good. Are you missing the intro music, or is...
I like the intro music.
Yeah.
It used to set the table. But then
Yeah.
producer Brenna said, no more. Change the name. Change the format. Do what I say.
Going natural. But
I'm not on camera, but I'm shaking my head just so everyone knows.
Yeah. Well, Rick was experimenting with some beats over there, so we might come up with a new intro fairly soon. There it is. Brenna's shaking her head.
It's so loud.
He has not perfected that yet, so we're going to need to see.
For those of you whose eardrums I didn't destroy just now, Danny, what do you want to talk about, man? I mean, I guess we have more freedom, is my understanding.
This is an open forum to talk about whatever we want to talk about.
Open forum.
You know.
Is there anything that's been tickling your brain here recently? Do you want to... Or actually, before we get into that, do you want to tell me a dad joke?
Well... You're putting me on the spot, Rick.
Look at this. This is a new... This is turning over a new leaf. We have a new name. I'm going to start requesting dad jokes from you and putting you on the spot.
Putting me on the spot. All right. What was this? Oh, I think Brenna sent me a joke.
I did.
That I might have to throw out there.
I send Danny jokes if I see them on
Yeah.
Facebook.
So let me throw this one out there because we haven't used this one yet.
Isn't Facebook just one big dad joke?
I would say so, yeah.
Okay, Rick, ready?
Pouring ready.
Do they allow loud laughing in Hawaii?
Yes.
No, just aloha.
That's yeah.
Weak sauce?
Yeah. That's
Little weak sauce. I thought it was pretty funny.
That's not your best.
It's hard to read out loud.
Yeah.
Like, I feel like that's a hard one to read out loud.
It is.
I should have said that before you read it.
That's all right.
It's not your best.
All right. Let me flip to my
give
book
us a good one.
here. Okay. I've got a few saved up here. Thanks, Dr. Sugarman, for hooking me up with this book, by the way. Rick's thankful to you as well. All right. What's the best snack to eat during a scary movie?
I don't know.
Obviously, ice cream.
Not bad. It's better.
I'll do one more.
Okay.
I'll do one more.
We're heading in the right direction.
So, okay. Why did the guy lose his job who worked at the orange juice factory?
You got me.
He just couldn't concentrate.
That's not bad. I like that one. That's the best one.
The mic is dropped. Now, back to topics.
God.
We gotta have a mic drop sound after my jokes.
Do you want a mic drop or do you want like a...
Yeah, either one would work.
Well, they're vastly different. So which one?
Oh, yeah. You don't want me walking out of the room after the joke. Yeah,
No.
okay. All right. Let's do some drum roll before the joke and then cymbal right after.
Okay.
Yeah. Let's do that. I like that.
Gotcha.
So, what do you want to talk about?
There's a lot of topics to talk about, Rick. What about these COVID vaccine booster shots? You want to talk about that?
Sure, we can. I think we're recording this on April 29th, 2022.
Just so we don't look too irrelevant with our topics.
Well, right. I just also, things change, right?
Things change.
I mean, I think, thankfully, knock on wood, hopefully, it seems like at least the seroprevalence of this virus is pretty much permeated most of the United States. I mean, would you agree
think
with
they
that?
said-
Disagree with that?
I saw like a 60% infection rate or something out
Yeah.
of the whole U.S.,
Seems
which seems
low.
low. Seems very low. But that's, I mean, these are like, what, documented infections
Right.
of either people
That's true.
reporting a self-test or
Right.
having actually
It's true.
a drive-through
I would
test.
imagine at this point, I mean, I think it has to be through most of the population that's been out and about has probably been exposed to it, I would imagine.
Yeah. Especially with Omicron, I can't imagine that. I mean, that rate of infection. And I think there were a lot of infections that didn't get documented for
Oh,
Omicron.
for sure. I think most people,
Had
unless
sinus issues
there's
that
like, well, I think a lot of
were-
people just stop testing because it hasn't changed what you would
100%.
necessarily do.
Even with an exposure within the house,
Right.
you might not have tested yourself.
Right.
Maybe.
Yeah.
But anyways, so the fourth booster is the hot topic now. Should you get it?
So, yeah. Wait.
Or fourth
Shot.
shot,
Third,
second booster.
second booster. Yeah.
Yeah, you're right.
Yeah. I mean, I don't know. I think if you're in a very vulnerable population, older, immunocompromised,
Yeah.
I don't see any reason why it wouldn't help. But outside of that, it seems to be data's kind of
I think that's where your hands are up a little bit too. Is like it makes sense for the immunocompromised population, but is it actually needed?
right.
For that population, and even for the general population who have gotten 3 shots and have overall intact health without a compromised immune system, especially with Omicron and being a less deadly variant out of the variants that have been circulating.
Yeah, I don't know. I think you read even in like the immunocompromised population, there seems to be I saw a study looking at cancer patients specifically with solid tumors.
Mm-hmm.
They don't have the same B cell immunity, but they have very robust T cell
Right.
immunity. So how much does that change factors even without the third booster?
Mm-hmm.
It's just an interesting time because I think there's a segment of the population that will keep getting the boosters, and
Yeah.
that's totally their prerogative. And then I think there's a segment of the population that seemed like at least had to get kicking and screaming to get any vaccinations, who probably
Right.
won't
Yeah.
even think about doing anything. So it's sort
Right.
of how do you balance those two things? I don't know if there's an easy.
Yeah.
Well, there's definitely not an easy answer.
I think right now it's for someone who's not on cancer treatment, not with a compromised immune system, it's kind of a personal choice, whatever you feel is best for your body and your comfort level.
Right.
Some of the data that got reported recently was saying 4th dose in patients without compromised immune systems had a roughly 50% reduction in infections compared to those with 3 dose, but the effect disappeared by 8 weeks. And so you say, it's effective, and I don't think anyone denies that it would be
But
effective.
is that just testing for an infection, or is that people self-reporting and having symptoms with an infection? Because in the study, I imagine they're just swabbing people.
I think so, right. I think it would have to be a positive test.
So it's basically, are you colonized or not?
Right.
Which does that even
So
any other?
more,
Go ahead.
yeah, it's more of severe COVID, right? We want to prevent hospitalization and severe illness. And they kind of state in here that, the protection was noted by the 2nd week after the 4th dose, protection still peaking at 6 weeks. And
Protection meaning what? Antibody levels?
No, I think they saw less severe infections. They're just comparing
Oh, so they actually compare.
the number of patients with severe infections, and then they said roughly 2/3 among the 4-dose recipients had a lower rate of severe infection. So, pretty good number of patients, but I still think, and I don't have the absolute numbers here, but it has to be low generally
Yeah.
for severe infections with Omicron. In people that had 3 shots, you would imagine that those people maybe didn't have the best robust immune systems.
Yeah, I think
Because most people who've had 3 vaccinations are not getting severe COVID from Omicron. I think that was pretty clear.
Yeah, no, I mean, I think to me it just is if you're in the most vulnerable population or you have a personal desire to get it, I think it makes sense. But outside of that, it seems
Yeah.
maybe the juice isn't worth the squeeze.
Yeah. Is it harmful? Probably not.
No.
But
Right.
how much benefit you're getting out of it. And I tell patients now, I mean, it depends on the patient's situation, of course, but if they're on some therapy that we know is compromising their immune system, I think the benefit outweighs the harm from the treatment by getting a fourth shot. But if they're not all that immunocompromised, they're not on immunocompromising treatment, I kind of tell them what this is saying, that you may have a benefit for 2 to 3 months from it,
Right.
but
Right.
if it's not a high infection rate now in our area,
Right.
I don't see a real need to do it.
Right.
And if you don't have travel plans,
Right.
to where you're going on trips across the country and exposed to people who you may not know what their status is. So that's what I think.
Sounds pretty reasonable to me.
Reasonable. So what else?
Try not to wade too much into controversial waters.
No. Yeah. What else? We can jump topic to topic, but it can be whatever,
Yeah. I mean,
I
think,
don't know.
Yeah, I think everyone's tired of.
COVID.
Uh,
So a lot new on our research front, actually. I'm kind of excited about that. A lot of new studies being open. We just got a new MDS. I'm not going to name all the names of the study because we can't do
the
that.
one you sent the email about?
New MDS study
that's cool.
coming out, which
like
is
that one.
investigating standard of care treatment plus oral
Go through for the
therapy.
listeners. What's
Yeah.
MDS?
So MDS is myelodysplastic syndrome. It's considered a blood disease that's lumped under a blood cancer, but what it really is a precursor to acute leukemia. And there's varying risks to, how we guide patients on what their risk of getting leukemia is. But when you have myelodysplastic syndrome, you carry a risk of that turning into usually acute myeloid leukemia. And we treat it based on symptoms and based on how likely we think the patient is to turn into leukemia and how soon. And usually it's a lot of supportive care. So if patients have low blood counts, we try to make their blood counts better with different therapies. And sometimes patients are at elevated risk to turn into leukemia to where we think in the next 2 years, their risk is like 50% turning into leukemia. And so those patients benefit from being on usually injectable therapies that try to help normalize their blood counts or at least get them to a point where they're...
How do they work? Are they trying to stimulate is it like a typical stimulant of kind of the early cells in the cell line, or are these drugs that are actually trying to inhibit the MDS process and transformation?
So both. So we have growth factors that help stimulate blood production. So those are drugs like EPO, which is a hormone that helps your body produce more red blood cells. We have growth hormones that help produce white blood cells, so we can give those. And then we have drugs which are chemotherapy agents, but they're a little bit in a weaker form than what we would consider normal IV chemo that we give to patients. And they work by trying to get your bone marrow to pump out more normal blood cells. And they do it in a mechanism to alter the way genes are expressed and different things. But the general gist is to get your bone marrow to function more normally and produce more normal blood cells.
Turn down basically the ones that maybe
the genes that are causing the abnormalities in the cells.
Proliferation, basically. Yeah.
So, and that's been the mainstay of treatment for these patients for a long time. Is we give it usually in an injectable form, and it's a standard of care. And we have a trial now open to patients. And we screen patients for a certain protein expression on those blood cells that if they do have this protein expression on their blood cells, they're eligible for the trial, and it's randomizing people to the standard of care or the standard of care plus a pill that has been shown to be really effective for patients with that protein expression.
That's cool.
It almost doubles the response rate.
Wow.
So
that's awesome.
So we're really excited about that. And a lot of other trials going on here.
Yeah, I mean, then we got the Pacific trial, the kind of the 4, I think, which is really for early stage lung cancer patients who are treated with radiation up front, which is a standard of care for early stage lung cancer, either in patients who don't want surgery or patients because of other medical problems can't get surgery.
Mm-hmm.
The standard of care is, targeted radiation. And now we're seeing in this trial is does giving immunotherapy, which we've talked about extensively on other episodes, does giving it after radiation, does that increase, people's chance of being cancer free as well as maybe increasing their lifespan long term? So I think that's pretty exciting to see it in that in that setting, and we have that open here. And then we have some of our other trials like the PSMA treatment trial, which I know we've talked about before. But I guess as the unofficial theranostics person, definitely a plug for that trial. So newly diagnosed metastatic prostate cancer. So patients who have new prostate cancer that's moved outside of the prostate can be eligible for that. Testing whether adding this novel radioligand agent, which is a radioactive molecule linked to a protein that's specific for prostate cancer. So it's injected through an IV, similar to what medicines Dr. Danny usually gives. And then it travels around your body. And what it's supposed to do is anywhere there's this protein which matches to your prostate cancer, deliver radiation, which is pretty cool mechanism of action. And so, yeah, it's lots of really good treatment trials actually going on right now, which is pretty cool.
Trials. Yeah, a lot of more targeted treatment trials, people with specific mutations that now we're screening pretty much everyone for. So.
I think, this has been the buzzword in cancer care, I feel like, for the last 15 years, but targeted therapy, precision oncology, all the buzzwords that people love to use. That's obviously the holy grail as we get to that point where we can screen you for all these different things, whether it's markers for Danny's medicine. There's now panels looking at radiation sensitivity. So some tumors, are they more radiosensitive, less radiosensitive? That could allow us to dial up the dose, dial down the dose, give no dose.
Yeah.
So there's, all these different things being looked at. So hopefully we'll arrive at a point where in folks who have cancer, we'll be able to give even more personalized and customized regimens at a way that, hopefully doesn't break the bank.
Did you see some of that? I looked at, there was a PowerPoint presentation of the year review in prostate trials, like cancer trials, and
the Decipher
PSMA ligand therapy, and I think it was Keytruda with it. I think it might have been a phase 2 study.
Yeah.
But it's very, it's, I think, awesome that we're looking at these combinations that, and not just Keytruda. I'm not plugging Keytruda, but I'm just saying it's cool that we're looking at these combinations that are novel, that, it's not just the same old taxane therapy.
Yeah, I think, because I think in the studies that looked at immunotherapy alone for prostate cancer, they've kind of been
iffy, with the exception of TMB status and even MSI, right? So where we do have approval for immunotherapy.
Right. I just meant it moving.
Yes.
It hasn't really moved up the ranks because it's kind of a relatively narrow window.
It is.
But you wonder if you would give it with a drug that breaks up the antigens of the tumor, like radiation.
Right.
In theory, would that allow for more immunoactivity, with antigen recognition and, all the rest?
Sure.
I think it's worth, I'm glad these studies are being done. It's worth looking into. But yeah, we gotta prove it on the study level before it becomes, I think, mainstream. But
one of the hot trials that I saw pop up on the feed too is Hot Trial.
Hot Trial.
We should actually plug that, Hot Trial. I doubt anyone's using that in other podcasts.
You should
Maybe
question when someone hasn't used something. You should always question why.
Maybe I'll name the episode Hot Trial.
It flows off the tongue. Yeah, what are they?
Quit while you're ahead.
Come on. All right.
So one of the hot trials.
One of the hot trials. Has been combining immunotherapy, whether it's PD-L1, PD-1 inhibition in melanoma, with BRAF inhibition. And actually, this is one of the pitfalls that we've been talking about with trials and early approval for therapies based on progression-free survival. And another trial just got reported. You combine a PD-1 inhibitor with BRAF, and you don't do any better than just the BRAF inhibition by itself.
Right.
And I don't know if it was Tecentriq or which immunotherapy with BRAF inhibition but it got approved based on PFS. And then, of course, 2 subsequent trials, I think it was 2, debunked that and said...
So they didn't even have a PFS benefit.
No. Not in this current trial, no, and
Right.
OS definitely not.
Right. Well, yeah.
So,
yeah.
so it just goes to show
if you can't even meet PFS when you're adding therapies, then what are we doing here?
And what's scary, though, is... And I haven't done this in practice. I know I work with Dr. Sugarman. She hasn't done this in practice. And we've come across a couple patients who haven't been treated at our own center, but who have been on that combination.
Right, because then what do you do when they fail?
Yeah, but they've been on that combination, and you say, why? Because there's really not good data for it. And even before this trial came out showing that, okay, there's no survival benefit, it just goes to show you that there are some providers out there that will start you on a new therapy before they actually interpret the data appropriately,
I've run into this a lot, which is basically newer is not always better.
Newer is not always better, right?
Novel doesn't necessarily mean better.
Right.
You need to prove it.
Yep.
And sometimes trials are designed in ways that don't really prove it, but they are designed in a way that get approval.
Yeah.
That'll be my slogan.
That's
Prove
true.
it, not just approval. And I think that's
I
really
like it.
the
Hot trial.
that's
This
this is a
You guys went 2 different directions on that.
I just like
I could have my own series of 20
Yeah.
podcasts about my thoughts about all that. But yeah, that's
maybe we should do a weekend edition with Rick talking about
no,
this.
that would just be me like Bernie
Rick,
Sanders
Rick
yelling.
4 beers
Disapproval.
deep.
That would just be me like
Let
Bernie.
me tell you.
I would just be like
Let
Bernie
me-
Sanders yelling to nobody, and no one would be listening, and I would just be yelling.
As
about
long
it.
as you talked a little bit about golf between, someone would listen.
No, I think everyone's like, turn this guy off. But yeah, no. So that's it's you just have to be very careful with how
Yeah.
you. Just because something is approved doesn't mean it's better. Doesn't mean a patient should get it. It's very tough,
Yep.
especially when there's in a good way. There's a lot of new data and new drugs coming out at rapid paces, but how those get actually applied to patients, takes some art of medicine as well as the science.
100%.
Well, thank you guys for listening to the first episode of the Rick and Danny Show, presented by Cancer Specialist Medical Minute.
Nope.
Oh, you're right.
Oh,
See,
Rick.
my brain is just ingrained with the old name.
It's okay.
take-
We could take 2 on that. We'll
Thanks.
just keep that in the podcast.
Okay.
Yeah.
Thank you guys for joining us on our first episode of the new Rick and Danny Show, presented by Cancer Specialists
Of North Florida.
of North Florida.
Nice.
That was
Thanks,
good.
guys.
Yeah. So
All
do we
right.
have a social media we direct them to now?
Not yet. Hey guys, producer Brenna here, coming at you from the Pod Loft. At the time of our recording, we did not have social media, but we have it now, thankfully. So I wanted to cut this in here. You can find us on Twitter at Rick Danny Show, on Facebook and Instagram at Rick and Danny Show, and on YouTube at The Rick and Danny Show. If you have any questions, comments, dad jokes you want to share, if you're Dunkin' Donuts and you want to sponsor us, you can send us an email to rickanddannyshow@gmail.com. As always, we're available wherever podcasts are found, and please make sure you rate and review us on Apple Podcasts and Spotify. It really helps us in the charts. We need to prove to Rick that we do in fact have listeners.
Found wherever podcasts are sold.
And
Podcasts are sold.
to be
Some podcasts
presented
you have to
to
pay
you
for.
by also Dunkin' Donuts.
We could open up a Substack or a
Ooh.
Patreon.
Patreon.
I think we got to get listeners first.
We have listeners.
Yeah.
$5 a month.
Do we have a? Oh, you said we have a. We have a.
We have international listeners. Rick.
Do
We
you
have
want to open our next episode with that
national
one?
and Thank you guys. See you next time.
Peace.